Sir, last class what we talked about so far was how basic definitions about stroke. We talked about the neuraxis. Now what we'll go, we'll first try to cover everything that we know about, we should know in theory. First we'll start with what are the types of stroke that you know of. ठीक है, अभी तक हमने बोला कि स्ट्रोक क्या है, इसकी डेफिनेशन में बात की, what are the terminologies related to stroke उसकी हमने बात की. Now we should know what are the types of stroke that you know. So remember, मैंने पहले भी बोला है कि stroke जो है, it is a vascular disease. Now remember, if you talk about a vascular disease, it can be either arterial or it can be venous. So somebody asks you, is a stroke possible as a venous stroke? Then yes, it is possible, but the chances of the incidence is only 1%. So this is either a stroke can be an arterial stroke or it could be a venous stroke. Now this definition venous stroke, again not of very much importance, but one of the causes for venous stroke will be a parasagittal meningioma. So if and if only you find this on imaging, you can diagnose it. So this is a parasagittal meningioma. Again, very, very unlikely. Or they can be, you know, that this is how the dura mater ends. So this is the sagittal section. This is how the falx cerebri is formed. Here, if there is thrombosis, so if there is a thrombosis over here, then it can lead to a possibility of, so if there is a thrombosis of the superior sagittal sinus, thrombosis of superior sagittal sinus, sagittal sinus, and this will lead to a venous stroke. We're done with venous stroke, not of much importance. Concentrate more on arterial stroke. Now remember, the artery में क्या है कि artery में there are two possibilities. See, if this is the lumen of the vessel, there may be a blockage or an atheromatous plaque which is sitting here. This gets disrupted, and then this will lead to formation of a thrombus. Or the thrombus was formed somewhere else. A part of it got dislodged and occluded the lumen of the vessel. That means it can be a thrombotic stroke or it could be an embolic stroke. Simple. थ्रोम्बस अगर वहीं बने उसी वेसल के अंदर बन रहा है अपने आप, इट इज अ थ्रोम्बोटिक स्ट्रोक. इफ द थ्रोम्बस gets dislodged from somewhere else and now a part of the thrombus is blocking the vessel lumen, it is called an embolic stroke. So remember, arterial strokes can be thrombotic strokes and embolic strokes. Okay, but these two predominantly will cause ischemia. मतलब कि क्योंकि इसकी वजह से आगे ही ब्लड सप्लाई ऑक्लूड हो गई है, तो आगे के जो ऑर्गन है, जो भी पार्ट ऑफ द ब्रेन जो सप्लाई कर रहे हैं, दैट विल बिकम इश्चेमिक. सो arterial stroke can be divided into two. It can be an ischemic stroke where ischemia will set in, again very common, or it could be a hypertensive hemorrhagic stroke. Hemorrhagic stroke. अब फर्क क्या है दोनों में, बहुत इंपॉर्टेंट इनको डिफरेंशिएट करना. सी, इश्चेमिक स्ट्रोक में क्या है, फॉर एग्जांपल ये आपका वेसल ल्यूमन है, ये आपका सप्लाइड ऑर्गन है, जो भी सप्लाइड पार्ट ऑफ द एरिया ऑफ द ब्रेन जो भी सप्लाइड है. नाउ इन केस इफ दिस गेट्स ऑक्लूडेड, ये बंद हो गया, तो आगे ब्लड सप्लाई नहीं जाएगी. अगर आगे ब्लड सप्लाई नहीं जाएगी तो इसकी ब्लड सप्लाई कम होने लगेगी. एंड लास्ट क्लास में टॉक्ड अबाउट द नॉर्मल ब्लड सप्लाई शुड बी मोर देन 25 ml. तो अभी द ब्लड सप्लाई विल स्टार्ट रिड्यूसिंग बाय 25. सो व्हेन इट कम्स बिटवीन 10 to 25, इश्चीमिया विल सेट इन. एंड एक बार द ब्लड सप्लाई बिकम्स लेस देन 10, इंफार्क्शन विल सेट इन. तो यहाँ प्रॉब्लम नहीं है. This is ischemic stroke. But what is happening in a hemorrhagic stroke? First of all, this vessel is damaged. So, if this vessel gets damaged, what happens? There will be more of spill of blood outside. और obviously जो target organ है उसको भी blood supply कम मिलेगी. तो पहले तो target organ की blood supply कम हो जाएगी. Second thing, ये जो blood बाहर जा रहा है, this will increase the intracranial pressure. क्योंकि remember, the brain is in a cranial vault. The brain is in a cranial vault. ये फिक्स्ड है, ये फिक्स वॉल्यूम है. यहाँ आपके पास में ब्रेन है, यहाँ आपके पास में सीएसएफ है, आपके उसमें ब्लड है, ये 3 कंपार्टमेंट है, ये फिक्स प्रोपोर्शन में फ्लो कर रहे थे। अचानक से एक कंपोनेंट अगर बढ़ जाएगा तो ये इन दोनों को कंप्रेस करेगा, इन दोनों को कम करने की कोशिश करेगा। सबसे इजी है ब्रेन को कंप्रेस करना, तो ब्रेन के ऊपर प्रेशर सिम्टम्स भी आ जाएंगे। यानी देयर विल नॉट बी ओनली वन चीफ कंप्लेंट, दैट इज बिकॉज ऑफ द reduced oxygenation of a particular area, लेकिन there will be compression symptoms also. So therefore hemorrhagic stroke is more difficult to manage, ये पता होना चाहिए पहली बात। दूसरी बात, there are double pathologies which are taking place. पहला, so there will be ischemia of the, or there will be infarction of the underlying tissue, and also there will be raised intracranial tension. So remember, in a hemorrhagic stroke there will always be raised intracranial tension, and this is the troublesome part for us. Any doubts so far? Okay, fine, great. So what we've talked about so far, कि जब भी हम बात करते हैं स्ट्रोक की, हम स्ट्रोक को 2 पार्ट में डिवाइड कर देते हैं। आइदर अ वीनस स्ट्रोक विच गॉट ओनली 1% ऑफ द इंसिडेंस, एंड द आर्टीरियल स्ट्रोक। जब हम बात करते हैं आर्टीरियल स्ट्रोक की, तो आर्टीरियल स्ट्रोक में देयर कैन बी इश्चेमिया व्हिच विल सेट इन, एंड देयर कैन बी hemorrhage which can set in. Now the problem with hemorrhage is कि apart from managing जो आपके पास में ischemia हो रहा है, उसके अलावा what you have to manage is the raised intracranial tension. Okay, so the commonest etiology for hemorrhagic stroke becomes hypotension. Hypertension. So we limit our discussion mainly to ischemic stroke, लेकिन ऐसा नहीं है कि एग्जाम में आपको मिलेगा नहीं केस hemorrhagic का। We'll briefly touch upon the management के टाइम पे कि what is a hemorrhagic stroke and how do you manage hemorrhagic stroke. We'll talk about that. Sorry. Okay. Talk about ischemic strokes. Now, as we already talked about, the ischemia can be because of a thrombus formation, or it can be because of an embolization of a thrombus. So it could be a thrombotic stroke, or it could be an embolic stroke. Right. अभी एम्बोलिक को भी 2 पार्ट में डिवाइड कर सकते हैं। तो इट कैन बी, ऐसा हो सकता है कि जो एम्बोलस है दैट इज फॉर्म्ड इन द हार्ट इटसेल्फ, दिस एम्बोलस इज फॉर्म्ड इन द हार्ट, it gets dislodged and via the aorta it has reached the brain. So that will be cardiogenic emboli. Cardiogenic emboli. The other possibility for emboli would be artery to artery emboli. Okay, इसका मतलब क्या समझिए, आर्टरी टू आर्टरी एम्बोलाई। अगर एक एम्बोलाई होना है तो उसके लिए आपको पहले से एक थ्रोम्बस का फॉर्मेशन होना जरूरी है। तो व्हाट हैपेंस इन केस ऑफ एथेरोस्क्लेरोसिस, बॉडी के जो मेजर वेसल्स हैं they will start getting damaged and they will lead to formation of an atheroma. So what happens? Most common is just the carotid artery. So carotid artery, you'll have atheromatous plaque formation. So now, if this plaque becomes unstable and ruptures and leads to formation of an thrombus, a part of the thrombus gets dislodged and reaches brain. So this can lead to stroke. This is called artery to artery emboli. So you can have a carotid artery emboli. ठीक, अभी हम बात करेंगे दूसरी आर्टरी की। अभी आर्टरी एंड वेसल्स का थोड़ा सा प्रॉब्लम, क्योंकि हमने ब्लड सप्लाई ऑफ ब्रेन की बात नहीं की है। कम टू दैट आज। So there are two systems that apply the brain. One is called the carotid artery system, that is the internal carotid artery system. The other system is the vertebrobasilar system. We'll talk about what is the vertebrobasilar system. Vertebrobasilar system. Vertebrobasilar system. But whatever happens, there is something called as a vertebral artery. The two vertebral artery will join to form the basilar artery or the pontine artery, which will give a lot of branches and will terminate by forming the posterior intercostal artery, posterior interocerebral artery, posterior cerebral artery. Sorry. So what happens? If there is a stroke, so if there is a emboli in the vertebral system, this can also, so there is a thrombus in the vertebral system. This can get dislodged and can present anywhere. So that means vertebrobasilar artery emboli. So that means there can be thrombotic stroke, there can be an embolic stroke, there can be a hemorrhagic stroke. Okay. So the commonest will be a thrombotic stroke or an embolic stroke. Embolic strokes are more common in young. Remember, they're more common in young. Okay. Very favorite question of the examiners, if they wish to ask, they'll ask, what is the incidence of embolic to thrombotic stroke in young? So remember, the incidence is 3 or 4 is to 1. That means in a young individual, what are the chances of having an embolic stroke than having a thrombotic stroke? It is 3 to 4 times more than that of a embolic stroke, of a thrombotic stroke. Similarly, they'll ask you a question: what is the chances of having a thrombotic stroke in an elderly? Elderly. So remember this. These are figures from Harrison itself. The chances are 9 is to 1, where 9 is thrombotic and 1 is embolic. Here, 3 is to 4 is embolic and 1 is thrombotic. Please make a note of this. So far, we talked about what are the types of stroke that we know. In terms of ischemic stroke, there are two possibilities. Either you can have a thrombotic stroke, जहाँ thrombus उसी vessel में बन रहा है, brain की ही vessel में बन रहा है thrombus. That is either the anterior cerebral artery, the posterior cerebral artery, or the middle cerebral artery. इनमें से किसी एक artery में ही thrombus अगर बने, then that is a thrombotic stroke. Or it can be embolic stroke, जहाँ thrombus कहीं और बना है, वो dislodge हो गया. Now that can be formed either in the heart itself, which is called a cardiogenic emboli. Sorry. Or it can be formed in an artery to artery emboli. So it can be a carotid artery emboli or it could be a vertebrobasilar artery emboli. उसके अलावा so these will again be part of atherosclerosis itself. What is important to remember, embolic strokes are more common in young with an incidence of 3 or 4 times 4 is to 1, whereas thrombotic strokes are more common in elderly with an incidence ratio of 9 is to 1. Any doubts so far? Sorry. Yeah. Anything that you want me to repeat? We're good. We can continue. We continue. अगर कोई डाउट है तो पोस्ट कर. Okay, so it is very important to differentiate. Now this is what जब आपको पता चलता है कि whether it is an ischemic stroke or a thrombotic stroke, so this will help you to form the etiology of a stroke. Remember, always and always in a neuro case, especially when you talk about stroke, you need to give a 4-tier diagnosis that will contain FPAE, something called as functional, anatomical, physiological, and etiological. The etiology of a stroke, when you talk about, you can say either it is an ischemic stroke, a ischemic stroke slash thrombotic or embolic stroke, or a hemorrhagic stroke. That is what you say is the etiology of a stroke. That is why the importance of types of stroke. Next, we come to what are the causes of stroke. Very, very favorite question from examiners. So, what are the causes of stroke that you know of? Anybody who can try an attempt and write it in the chat box. What are the possible etiologies that you know of a stroke? Can be embolic, it could be hemorrhagic, it could be any. We are currently focusing on ischemic strokes. What are the etiologies that you have heard of? You have any idea? Anybody? What are the possibilities that you know of? Talk so we've talked it. Okay, very good. Atrial fibrillation, very nice, Anirudh. Atherosclerosis, absolutely correct. The commonest one, very good. Talk about the etiology. So remember, जब भी हम बात करते हैं स्ट्रोक की, it is a cardiovascular disease. Cardiovascular disease. हमेशा हमेशा जब भी आप कॉसेस किसी भी चीज की याद करते हैं, always classify them. The advantage will be कि आप उनको ज्यादा टाइम तक याद रख सकते हैं. Cardiovascular disease. Now, what happens in a cardiovascular disease itself? The cause can be in the heart, could be a cardiac cause, it could be in the blood, so it can be a hematological cause. It could be in the blood vessel, it could be a vascular cause. So remember, these are all the causes that you can think of. Okay. Hello. अच्छा ठीक. So now what happens कि जब हम बात करते हैं कार्डियक स्ट्रोक की, तो अगेन कार्डियक में यू कैन थिंक फ्रॉम इनसाइड टू आउटसाइड. तो इनसाइड टू आउटसाइड, सबसे पहले यू हैव द एंडोकार्डियम. तो एंडोकार्डियम में क्या क्या पॉसिबल डिसीजेज दैट कैन लीड टू अ स्ट्रोक. तो फॉर एग्जांपल इन्फेक्टिव एंडोकार्डिटिस. तो अगर इन्फेक्टिव एंडोकार्डिटिस है सेट इन, तो क्या होगा कि आपका जब भी इन्फेक्टिव एंडोकार्डिटिस होता है तो वाल्व इज इन्फ्लेम्ड, जो आपका एंडोथेलियम है एंडोकार्डियम इज इन्फ्लेम्ड. यहाँ देयर बी स्टेसिस ऑफ ब्लड. Once there is a stasis of blood, that will lead to formation of thrombus. And from the left ventricle, the thrombus can be easily dislodged. So one is infective endocarditis. The other possibility which can be possible is something called as paradoxical stroke. Anybody who's got any knowledge about paradoxical stroke can type in. We'll talk about this later after we finish the causes of cardiac disease. So there can be a paradoxical stroke. Next, आपने बोला एंडोमेट्रियम, सॉरी एंडोकार्डियम में इन्फेक्टिव एंडोकार्डिटिस होता है. मायोकार्डियम में आ जाइए. मायोकार्डियम में व्हाट आर द पॉसिबिलिटी? मायोकार्डियम में देयर कैन बी लेफ्ट वेंट्रिकुलर एनेरिज्म. लेफ्ट वेंट्रिकुलर एनेरिज्म दैट कैन कॉज अ स्ट्रोक. अगर आप बाहर की तरफ आ जाते हैं तो देयर कैन बी सीसीपी, कंस्ट्रक्टिव, नाम चेंज हो गया, कंस्ट्रक्टिव पेरिकार्डिटिस. कंस्ट्रक्टिव पेरिकार्डिटिस कैन लीड टू स्टेसिस एंड कैन लीड टू. इसके अलावा, सो दिस इज एंडोकार्डियम, दिस इज मायोकार्डियम, दिस इज एपिकार्डियम. इसके बाहर अगर आप आते हैं, यू हैव ब्लड वेसल्स. फेमस डिसीज फॉर ब्लड वेसल्स एथेरोस्क्लेरोसिस. एथेरोस्क्लेरोसिस. Dangerous disease from blood vessels is myocardial infarction. Apart from that, there's a disease, so blood supply हो गई, और nerve supply की disease है arrhythmias. The commonest arrhythmia that can lead to stroke is, as very well pointed out, is atrial fibrillation. These are all the possibilities of having a stroke. So once you're talking about stroke, we talked about the stroke की अगर हम बात करें, causes of stroke की हम बात करें, so since it is a cardiovascular disease, the causes can be cardiac, vascular, and hematological. जब हम बात कर रहे हैं कार्डियक डिसीजेज में, so think from inside to outside. So when can the endocardium be damaged? If there is an infective endocarditis or there is a rheumatic heart disease as well. So in case of any possibility for rheumatic heart disease, also if the valve is inflamed, it can lead to a thrombus formation. And there can be something called paradoxical stroke. We'll talk about this. In the myocardium, it can be a left ventricular aneurysm. In the endocardium, it will be constrictive pericarditis. Apart from that, there can be diseases of the blood vessels supplying the heart, atherosclerosis and myocardial infarction, and then it can be arrhythmias. So they can be arrhythmia. The commonest arrhythmia that can lead to stroke is atrial fibrillation. Apart from that, there will other causes like left atrial appendage. Left atrial appendage. That is your sorry, the left auricle, which you talk about the left auricle. So if there's a myxoma, atrial myxoma, which is present, that can lead to formation of a thrombus, and that will lead to formation of emboli that can dislodge. So these are all the cardiac causes. So now the question goes: does somebody know what a paradoxical stroke is? Any guesses? Okay. We'll talk about Danish versus Plasmin brain vessels. Does it cause stroke or not? What is a paradoxical stroke? Okay, so I'll tell you what the paradoxical stroke is. So this is very funny. What happens? There is a deep vein thrombosis in a patient. So make this right. This is my patient. He's got a deep vein thrombosis somewhere in this vessel. He's got a heart supplying the brain. This goes to the right side of the heart. So a venous stroke, remember, sorry, a venous thrombus causing an arterial stroke. How is it even possible? It is possible only and only if there is some connection here, because we know that this is the part of the heart that has got all the thing to do with the venous return, and this part has got all the thing to do with the arterial system or the pumping system of the heart. Now, unless and until there's a defect over here or here, the vessel, see, the thrombus won't get dislodged. So, a venous thrombus via a patent patent foramen ovale enters into the arterial system of the heart and then causes an arterial stroke. This is called paradoxical stroke. Paradox because a venous thrombus is causing an arterial stroke. Again, very favorite question of the examiners. Can there be a possibility of paradoxical stroke? Again, paradoxical stroke is because of a patent foramen ovale most commonly. It can be because of other reasons as well, but it will be because of a patent foramen ovale. And remember, in 3 to 4% of the population, we have patent foramen ovale as a normal finding. So the patient might not even be aware of it, and this may be the reason for stroke. Especially, make a note of this, put a star over there, and write it. Patent foramen ovale is a reason for stroke in young. So any stroke that occurs in a patient age less than 40 years is said to be stroke in young. And they'll ask you what are the causes of stroke in young. So one of the causes of a stroke in young is a patent foramen ovale, also called a paradoxical stroke. Are we clear so far? Any doubts so far? Right, right. Danish and Disha, absolutely correct. Any doubts so far? Okay, so there are no doubts, so we'll move forward. Okay. So now we first will talk about hematological causes and then come back to vascular causes. Now hematological causes जो है because of blood vessel में है कुछ sorry blood के अंदर है कुछ anything that causes thickening of the blood. So what are the causes that you know of thickening of the blood? Okay, and I'll tell you the causes for thickening of blood, which is hyperviscosity of the blood. Remember these reasons in the same manner, and wherever anybody asks you, just rattle them out. क्योंकि ये कांस्टेंट रहते हैं, ये सेम रीजंस रहते हैं. आप चाहे रिकरेंट प्रेगनेंसी लॉस पढ़ लो, वहां भी ये सेम रीजंस मिलेंगे आपको. ठीक है, आप पढ़ लो थ्रोम्बोसिस इन प्रेगनेंसी पढ़ लो, वहां भी आपको सेम रीजंस मिलेंगे आपको. आप पढ़ लो अर्ली अबॉर्शंस पढ़ लो, फर्स्ट ट्राइमेस्टर अबॉर्शंस पढ़ लो, वहां भी आपको सेम रीजंस मिलेंगे. तो एनीथिंग दैट कॉजेस thickening of the blood, remember thickening means hyper viscous blood. Thickening or hyper viscous blood. Hyper viscous blood. So remember, जब भी आपसे कोई ऐसा कुछ पूछे hyper viscous blood, rattle out these findings. First finding, the first cause will be factor 5 Leiden mutation. Leiden mutation. Okay. So this comes under a heading called as inherited thrombophilias. So this is hereditary. Inherited thrombophilias. Thrombophilia. In this, you have the first cause as factor 5 Leiden mutation. The other reason, which is it is and protein C deficiency, protein C deficiency, protein S deficiency, antithrombin 3 deficiency, antithrombin 3 deficiency, prothrombin. I think it's prothrombin mutation, like deficiency. Prothrombin mutation. Apla syndrome, Apla syndrome, that is anti-phospholipid antibody syndrome. So these are inherited causes. Other causes will include sickle cell anemia, sickle cell anemia, polycythemia. So these are all the causes of hematological causes. We talked about inherited thrombophilias and other causes. These are not thrombophilic states. These are basically the RBC is more. Now, because of the RBC itself being more, RBC itself being more, they lead to hyperviscous blood. So these are all the causes of inherited thrombophilias, and these are other causes for other hematological causes for stroke. So one is sickle cell anemia, other is polycythemia. So if there's a history of say stay in a high altitude, one of the causes can be polycythemia. So again, put a star on this entire column, and these are all the causes for stroke in young. So when somebody asks you, what are the causes of stroke in young? You say either it can be cardiac cause, like a petrol foramen obelisk or a paradoxical stroke, or it could be hematological cause. Hematological, it can be because of inherited thrombophilias, or it can be other causes. Other causes like sickle cell anemia and polycythemia, because the red blood cell volume has increased, so there is more of red blood cells in the blood, and that is because of which will be hyperviscous blood that will predispose to formation of thrombus, or it can be because of inherited thrombophilias. So that means, what is the meaning of an inherited thrombophilia is, see, there's always a balance between the thrombotic state and the antithrombotic state. So what will happen in these conditions, the thrombotic state, the ability to procoagulant state which is there, that will increase, and the antithrombin state which is there, they'll reduce. So like protein C, protein S, antithrombin 3, these are antithrombotic. So once there is a relative deficiency of this in the body is predisposed to formation of thrombus. If there's a prothrombin mutation, the thrombus which is formed will be automatically triggered up. Apla syndrome is again, there's a cluster of autoantibodies which are formed, like the lupus anticoagulant, and that will lead to formation of thrombus. Sorry. Yeah. So this entire gambit comes under the heading of hematological disorders. Remember, hematological disorders are one of the commonest causes for stroke in young. However, they can also cause stroke in the elderly. And the most commonest reason among all of them will be polycythemia because of the stay in high altitude. If we're clear with this, we'll move to vascular causes, which is again a very big list, very important list. You can keep your doubts posted. I'll check on them. And now we come to the vascular causes. Now remember, there'll always be doubt in vascular causes, what can cause stroke and what cannot cause stroke. Remember, anything that causes or that affects the blood vessel in the brain can cause stroke. So the causes can be inflammatory and non-inflammatory. Non-inflammatory. Let's first finish with non-inflammatory. First one is called the commonest one. That is first one is called atherosclerosis, a very common condition affecting blood vessels. The other cause, as a non-inflammatory cause, is something called as arterial dissection. Arterial dissection. There's a very good story I'll tell you about arterial dissection that is called stroke. The third commonest cause, or third non-inflammatory cause, is something called as CADA cell. Mm. And the fourth cause is moya moya. So these two causes are relatively uncommon, But if you tell them, that these are distinction points, unless and until you know what these are, do not utter this. Unless and until you know what this is, do not utter this. You can finish this by saying just atherosclerosis, arterial dissection. If you want to get brownie points, you can always say these two, but you should know at least something about them. We'll talk about them. First, let's talk about arterial dissection. You know what happens in arterial dissection is, so anything that can basically cause a dissection, that is break in the vessel, will lead to formation of a thrombus. This is a very common habit which happens especially in North India. यहाँ पे क्या करते हैं कि the male counterparts I'm talking about, they go for a good haircut. Once they get a haircut done, so the same barber will offer you a proper head massage. It gives a proper head massage. Now, in this attempt of giving a vigorous head massage, there are very common chances of hitting the vertebral artery, and in these that will lead to that will hit the vertebral artery, lead to dissection in the vertebral artery, leads to formation of thrombus, and that leads to stroke. Nobody could have thought of it. So these are real life scenarios which have happened actually, and that is one of the reasons why we know that atrial dissection, especially the vertebral artery dissection, as well as aortic dissection. The aortic aneurysm, there is a previous history of an aortic dissection, or there is an aortic aneurysm which is there, or there is history of syphilis. It is a history of syphilis. So all these causes will predispose individuals or will put them at a higher risk of developing stroke. And something like a very trivial head massage can also lead to stroke. This was very this has commonly happened in North India. Just a minute. Okay. Yeah. All right. Next thing that we need to know, what is Gardasil and what is Moya Moya. So please make a note of what is Gardasil. The full form for Gardasil is, it is cerebral autosomal dominant. It is cerebral autosomal dominant arteriopathy. The meaning of arteriopathy is we don't know what is causing the blood vessel to be involved, but the blood vessel is somewhat involved, and there's no actual inflammation which is going on in the vessel. That is why we call it arteriopathy. So it is cerebral autosomal dominant arteriopathy with subcortical subcortical infarcts and leukoencephalopathy and leukoencephalopathy. Cardiac is cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. Again, it is a idiopathic disease. We don't know the cause, but the blood vessel is involved, and that leads to thrombus formation. The other disease is moya moya, which is seen in children. It is a small vessel vasculitis. Moya moya. It is a small vessel vasculitis seen in children. Again, one of the reasons for Cardiac and moya moya, both are the reasons for stroke in young, moya moya more in children. So Cardiac and moya moya. We finished with non-inflammatory causes. Now we'll talk about the inflammatory causes. Remember. Okay. So as I rightly pointed out, inflammatory causes can be because of, the simplest reason is vasculitis. Now vasculitis can be divided into large vessel vasculitis. It could be a large vessel vasculitis. It could be a medium vessel vasculitis. It could be a small vessel vasculitis. तो अभी जस्ट लुक एट दी कॉसेज, याद करने की जरूरत नहीं है. जब आप रोमैट पढ़ेंगे आप अपना भी याद हो जाएगा आपको कि लार्ज वेसल में क्या है, मीडियम में क्या है, स्मॉल में क्या है. सो Large vessel, medium vessel, and small vessel. सबसे important है small vessel में you have something called as sorry medium vessel में you have something called as primary CNS vasculitis. Primary CNS vasculitis. Medium vessel vasculitis. The commonest reason will be a primary CNS vasculitis. When you talk about small vessel vasculitis, you can have something called as Wegener's granulomatosis. Wegener's granulomatosis. You can have microscopic polyangiitis. Microscopic polyangiitis. Large vessel vasculitis, you have something called as uh, Kawasaki disease. Forgetting the name of a large vessel vasculitis, there are two diseases which are there in large vessel vasculitis. Uh, you're missing the name of these two. I think, please check this out. I think it is Kawasaki's disease. No, it's not Kawasaki. Kawasaki is a small vessel vasculitis. Small vasculitis. The two diseases, one is called Takasaki arthritis. Okay, it's called giant cell. It is called a giant cell arthritis. Giant cell arthritis, also called as temporal arthritis. This is an example for large vessel arthritis. So what happens actually, vasculitis में जो आपका नॉर्मल ब्लड वेसल है किसी तरह मोस्ट कॉमनली कैन बी इम्यूनोलॉजिकली ट्रिगर्ड लेकिन इम्यूनोलॉजिकली ट्रिगर्ड there'll be inflammation of this vessel first of all. Apart from that, there'll be new vessel formation. So this will be more of leaky vessels and more of damaged vessels. तो इनके एंडोथेलियम प्रीडिस्पोज होते हैं क्योंकि वो पहले से ही डैमेज्ड है. तो ये ऑलरेडी एक डैमेज वेसल है जो ब्रेन के अंदर फॉर्म हो रही है और उसकी वजह से नई वेसल्स और फॉर्म हो रही हैं जो ऑलरेडी डैमेज्ड है. So there are more chances of developing a thrombus. That is why inflammatory causes, you need to remember vasculitis. It is very good if you can remember and break them into like this. It is large vessel vasculitis, medium vessel vasculitis, and small vessel. The most important of them is primary CNS vasculitis. Other are small vessel vasculitis, like Wegener's and microscopic polyangiitis. These are the commonest. Others will include Kawasaki, obviously, and large cell mein you have giant cell arthritis, which is nothing but the vasculitis of the superficial temporal artery. So these are the causes of vasculitis. Apart from that, now there is a very, very favorite question of the examiners. Does meningitis cause, meningitis cause stroke? Can tuberculous meningitis cause stroke? So I hope you can answer this question if you can type in yes or no. Can tuberculous meningitis cause stroke? Arthritis. Okay, arthritis. The problem with arthritis, it is a giant vessel arthritis, but it majorly involves the upper limb. It is more of an arthritis of the upper limb. Both of you are right. They are large vessel arthritis only, but they predominantly affect the upper limb. Okay. So my question to you is: can tubercular meningitis or any form of meningitis cause stroke? Yes, absolutely correct. The reason that has been given in Harrison is what happens with meningitis. Meningitis directly will never cause stroke because it is involving the meninges. So how can a vascular structure be involved? So whether it is a bacterial meningitis, also called the pathogenic meningitis, a viral meningitis, a tubercular meningitis, or a fungal meningitis, any of these. So any of these will lead to something called as arteritis, that is inflammation of the arteries, arteritis, and this will lead to stroke. And that is the very same reason why HIV causes stroke, is because it causes arteritis. I hope this is clear. So, what we've talked about, what are the causes of stroke? They can be divided into cardiac causes, hematological causes, and vascular causes. So we talked about cardiac causes and hematological causes. In vascular, we have inflammatory causes and non-inflammatory causes. The commonest cause for a stroke will be atherosclerosis, followed by other causes. For non-inflammatory, it will be arterial dissection. Again, I told you the story about the barber. Same happens with aortic dissection as well. Sorry. The next one is Cardacil and Moyamoya. These are the reasons for stroke in young. Cardacil and Moyamoya, these are again involvement of the blood vessel without established inflammation. This is seen more in children, and this is an idiopathic type of vessel involvement. We talked about inflammatory causes. Now, the inflammatory causes can be because of vasculitis and non-vasculitis. So, in non-vasculitis, there will be bacterial, viral, tubercle meningitis, and fungal meningitis that will lead to arteritis and that will lead to stroke. Same thing about HIV causes as well. The other picture, the other half is vasculitis, where there can be primary CNS vasculitis, Bejer's granulomatosis, microscopic polyangiitis, and other forms of vasculitis. With this, we come to the end of causes of stroke. Any doubts so far, or we can move forward? You type in your doubts in the chat box or as a WhatsApp message. Okay. So see, vasospasm, say for example, like we talk about anginas. So like vasospasm per se, there is very small chance of having vasospasm causing stroke. But yes, vasospasm can definitely cause an TIA. So if you ask me whether there is a possibility of having a vasospastic stroke, it is very unlikely. But having a TIA is more likely. So if there is a presence of a TIA, we'll talk about pathophysiology, what a TIA is, and how what are the types of TIA. So what happens? Even if there is a vasospasm in the brain that has occurred, there is a compensatory mechanism in the brain, and that will lead to improvement in the circulation. So if there is some part which has got vasospastic, there will be some sort of an autoregulation that will lead to cerebral vasodilation, and that will overcome that. But that does not happen when a thrombus is being formed or when there is an embolus or when there is a hemorrhage. And that is the reason why there is a manifestation of a stroke. See, the thin line between stroke and TIA was permanent neurological damage. So vasospasm per se cannot cause permanent neurological damage because it has to be very long processing for that. We'll talk about that. What is an ischemia time for a neuron? We'll talk about that. What is an ischemia time for a neuron? But that is actually 4.5 hours. But then a vasospasm for that period of time without cerebral autoregulation happening is very unlikely. That is why vasospasm per se will directly not predispose to stroke. I hope I've answered your question, Manish. Okay. Any more questions? Okay, great. So let the questions come in. Till the time we talk something about something clinical, something beautiful. Just call as risk assessment in stroke. Risk assessment in stroke. Okay. So what happens? There are some people tell you to write risks in exam. The examiner will ask you what are the risk factors for stroke, so you can divide them very easily. You know all the causes now, so you can divide them into low, high risk and low risk, high risk and low risk. So the patient has got a history of atherosclerosis, obesity, he's got atrial fibrillation. You can think of a cause and you can write it here. Low risk factors will include history of migraine because it is a blood vessel disease, the use of oral contraceptive pills, use of anticoagulants. These will put it at lower risk. Use of anticoagulants for hypertensive stroke. Okay. So these are the risk factors for stroke. Now there is something which is very beautiful that is called an ABC D2 scoring system. It's called the ABCD 2 scoring system. Basically, the importance of the scoring system. Again, this is a very good scoring system. So if a patient has got a stroke, he can have a restroke as well. And if there's a patient who's got history of TIA, he can also have a stroke. So patients with TIA or patients with stroke and risk of developing recurrent stroke. For those patients, we would love to do something called as A, B, C, D, two scoring risk assessment score or a risk assessment score. What are the components of A, B, C, D, two scoring system? I'll tell you. So A stands for age. If the age is more than 60, you give the patient 1 point. So it's basically you have to give points to the patient. You have to count how many points are present in your patient. So A is for age more than 60 years. B is for blood pressure more than 140 over 90. C is for clinical features. तो क्लिनिकल फीचर्स में है ये या तो स्पीच डिस्टर्बेंस हो सकता है स्पीच डिस्टर्बेंस speech disturbance or there could be unilateral weakness unilateral weakness either in the arm or in the lower limb there can be unilateral weakness may be present abc d2 d2 means d दो बार आएगा so d one is d is for duration so whether these clinical features are present for greater than or equal to 10 minutes or they're present for greater than or equal to 1 hour and then the other d is for diabetes mellitus. This is a scoring system that is used. Now remember, everything is given a one point except unilateral weakness, which is given 2 points, and a symptom present for more than 2 hours is given 2 points. Everything else is given 1 point each. A score of greater than equal to 4 is the chances of stroke or restroke. For these patients, put them on aspirin 75 milligram OD. Aspirin 75 milligram OD. That is the whole purpose of having an ABCD2 scoring system. So remember, this is a scoring system for the assessment of risk of stroke. It is used specially for chances of assessment of restroke in a patient or chances of assessment of stroke in a patient with TIA, where you give points for following criteria. The 2 points are given for unilateral weakness and 2 points for if the duration of symptom is more than 1 hour. And if the total score is more than 4, the chances of having a stroke. For these patients, you put them on aspirin 75 milligram OD. Any doubts so far? Okay, fine. So now we've finished with the risk assessment of stroke and also the causes of stroke. So we'll go to the second part of our answer. That is, what is the pathophysiology of stroke? So remember, the pathology of stroke can be divided into two parts. That is the pathophysiology and pathoanatomy. First, I'll discuss the pathophysiology and then I'll discuss the pathoanatomy of stroke. Okay. So, pathology of stroke we're talking about. And now we're talking about first the pathophysiology of stroke. What is the main problem in stroke? Is that there is reduced cerebral blood flow. That is the basic problem, ना? इसी वजह से इश्यू में हो रहा है. Now, why is this actually happening? Why is this entity happening? Is because so remember, cerebral blood flow that will depend only on something called as CPP, cerebral perfusion pressure. So it is this entity that decides कि brain में blood flow होगा या नहीं होगा. Cerebral perfusion pressure, which is equal to mean arterial pressure minus intracranial pressure. Please make a note of this equation. Very, 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 very important equation for the understanding of stroke. Something called as cerebral perfusion pressure. So this will decide the cerebral blood flow is occurring or not. And this is mean arterial pressure minus intracranial pressure. Now what happens? Any condition that causes a rise in intracranial pressure will cause a reduction in the CVP. That we know for sure. Any condition that causes reduction in the mean arterial pressure will cause a reduction in CPP. That we know. This is of lesser importance when you talk about stroke, but this is a very important ingredient when you talk about stroke. So far, what we know that there is a reduced cerebral blood flow, and this reduced cerebral blood flow is because of cerebral perfusion pressure. There is a fall in cerebral perfusion pressure because there may be either a fall in the mean arterial pressure or there may be increased ICP. Now remember the normal values. The normal value for cerebral perfusion pressure will be 50 to 150 mm of Hg, and the normal value for ICP is less than 15 millimeter of Hg. Everybody knows that mean arterial pressure normal value will be almost about 70 in an average healthy human. These are the normal values for cerebral perfusion pressure and determinants. So I hope this is very, very important, very clear. The question has to be in your mind. So what happens? I'll tell you the doctrine that happens. अभी क्या होता है कि जैसे फॉर एग्जांपल ये हमने बोला कि ये क्रेनियल वॉल्ट है, इसके अंदर में ब्रेन है, तो ब्रेन है, ब्रेन को सप्लाई कर रहे हैं आके ब्लड वेसल्स। ब्लड वेसल्स एक बार ब्रेन को सप्लाई करते हैं, उसके बाद में जो देयर विल बी फॉर्मेशन ऑफ सीएसएफ फ्रॉम दीस ब्लड वेसल्स। वो सीएसएफ विल अल्टीमेटली ड्रेन इनटू द venous sinuses. The supracerebral sinus will be reabsorbed and taken by the venous system. That means there are three compartments that exist in the brain. One is called the brain matter or the brain parenchyma. Along with this, there will be cerebrospinal fluid, and along with this, there will be blood volume. Now, what happens if any of this will increase? The other two has to reduce क्योंकि वो fixed space है. This is called the Monro-Kelly doctrine. The Kelly-Monro doctrine is there that says that the crane or the cranial vault exists as a fixed space. It consists of three things: the brain parenchyma, the cerebrospinal fluid volume, and the blood volume. So increase in any of one will cause compression of the others. And if there is a compression of the others, there will be signs and symptoms of compression of the others. So what happens in meningitis? There will be raised intracranial tension. The cerebrospinal fluid volume is already involved, and there will be reduced absorption of the cerebrospinal fluid because उसमें inflammatory exudates आ गए. There is reduced absorption. So both the volumes have increased, and that will severely push the brain volume. This is what is exactly happening when meningitis is going on. Similarly, what happens in a hemorrhagic stroke is that there will be increased intracranial tension because of the increased blood volume. As a result, the brain matter will be compressed, and there will be some features of compression of the brain matter. This is again a cause of raised intracranial tension. So, this equation is very, very important when we talk about neurological trauma, when we talk about neurological diseases, especially diseases affecting the cranial vault. This is very important. You must be aware about this equation. Okay. Something else called as the Cushing reflex. I'll not go into the details of that. That is a topic for neurosurgery to be dealt with. Sorry. We'll focus on stroke. So we said that there will be reduced cerebral blood flow. Sorry. And this will be because of the reduced cerebral. So this reduced cerebral blood flow is because of reduced is because of a reduced cerebral perfusion pressure. This is because of a reduced cerebral perfusion pressure. Now, this reduced cerebral perfusion pressure is because of a raised ICT. Tension is seen in cases of hemorrhagic stroke. Hemorrhagic stroke will lead to raised intracranial tension. They can be directly cerebral blood flow कम हो जाएगा. क्यों? क्योंकि if there is a thrombus if there's a thrombus that is set in, or if there is a embolism that is set in. So this will directly lead to reduction in cerebral blood flow. There will be reduced CPP, raised intracranial tension because of hemorrhage. This all will lead to ischemia. That means the blood flow has reduced. It has become less than 25 ml per 100 gram of brain tissue per minute. This ischemia will lead to infarction. Infarction. Infarction means कि वो सेल डैमेज हो गया, वो सेल डिस्ट्रॉय होगा, वो सेल से एक्सुलेट्स बाहर निकलेंगे. Now, so infarction and this will cause primary damage to the brain. क्योंकि वो एरिया लॉस हो चुका है, उसका यूज जा चुका है. यू कैन नॉट सैल्वेज दैट टिश्यू नाउ. प्राइमरी डैमेज इज कॉज्ड. नाउ इन्फेक्शन की वजह से व्हाट विल हैपन इज कि आपके पास में जो सेल के अंदर के कंटेंट्स थे वो बाहर निकलेंगे, सेलुलर कंटेंट्स बाहर निकलेंगे. दैट मीन्स कि जो सेल का फ्लूइड था वो बाहर निकलेगा, सेल के इलेक्ट्रोलाइट्स बाहर निकलेंगे. एक बार इलेक्ट्रोलाइट्स बाहर निकलेंगे तो फ्लूइड और अक्यूमुलेट होगा और उसकी वजह से देयर विल बी सेरेब्रल एडिमा. समझ में कैसे होगा? सी द मोस्ट abundant जो intracellular cation, that is potassium. So once the cell has got a dicell, the cell will rupture. There'll be release of potassium. So this potassium that comes out will draw fluid as well. So what will happen? There'll be more accumulation of fluid. Again, there'll be more accumulation of fluid that will lead to again raise in the intracranial tension. Once the intracranial tension will start to rise, it will cause compression of the brain structure. This is what we call cerebral edema. This cerebral edema will further lead to increase in intracranial tension, and this vicious cycle will continue, causing reduction in cerebral blood flow. There are two important things that you need to take from here. First is that infarction or ischemia causes primary damage. The cerebral edema will cause secondary damage. ये compression cause कर रहा है. It will cause secondary damage. So these are the two things that will cause the direct damage to the brain parenchyma. जो brain की जो areas हैं, it will cause damage directly to them. Important points. Why is there a reduction in cerebral blood flow? Because of the reduction in cerebral perfusion pressure. And why is there a reduction in cerebral perfusion? Because of the raised intracranial tension. However, there can be a direct cerebral blood flow reduction as well because of embolism or because of thrombus. This is the pathophysiology of stroke. And once this starts to set in, it is very difficult to reverse it back. But you must remember what are the things that are causing damage. So you know that if I can tackle ischemia, the patient can be well versed. If I can tackle cerebral edema, if I can reduce this edema, my patient will have less of neurological damage. See, the insult is caused, the damage will be caused. But as a neurologist or as a treating physician, your role is to reduce that damage to minimal. And obviously, because help in the rehabilitation. But here, if you know what are the things to manage, you know what you're looking for. So if there is ischemia, you look for signs of ischemia in the form of is there any history of TIA? Is there ongoing TIA? Is there an ongoing stroke? Is there any stroke in evolution? And is there any presence or setting of cerebral edema? Is there any raised intracranial tension? We'll talk about what are the features of raised intracranial tension. So if you see in a patient, there are some features of raised intracranial tension. Know that you need to first reduce the intracranial pressure. So you have to go for something called as anti-cerebral edema measures. That is how the pathophysiology will help you in the management of your patient. This is the exact pathophysiology that you need to write in your exams. Any doubts in the pathophysiology? We'll go to the next section, that is the pathoanatomy then. Any doubts so far? Anybody who wants me to repeat this? Not a problem, we'll repeat it. Any part that you've not understood? Anything that requires a clarification? Alright. If there are no doubts, then it is very good. You've understood this. With this, we'll also talk about the pathoanatomy, and then we'll close it for a day because it becomes too much of knowledge, too much of an information overload, which needs time to settle in your brains. So go back and start reading from the definition of stroke, and now try to articulate things. ये सबसे पहले stroke है क्या? Stroke क्यों हुआ? We talked about the causes of stroke. What are the types of stroke that you know of? Then think about the pathoanatomy, and then think about the pathophysiology. So articulate stroke in your mind, because stroke is something which is a medical emergency. All of us need to manage. All of us need to know what we are looking for. Okay, so now comes the favorite part, that is called the pathoanatomy. Okay, you must be in possession of a piece of paper for this part. First, starting these diagrams. I'm very bad at diagrams, but try to deal with them. Because these diagrams are very familiar with the books of neuroanatomy. So first of all, these are various sections of these are various views of the brain that we're talking about. So this is, I'll draw the caudate nucleus. So this is the medial surface. This is the superolateral surface, and this is the inferior surface. Inferior surface. That is very important to know कि कौन सी blood vessel कहाँ supply कर रही है. So if on the basis of a history and examination you are able to localize कि हाँ ठीक है, I know कि this is stroke, इसका मतलब है कि stroke जो है वो cerebral cortex, subcortical gray matter, subcortical white matter, thalamus, basal ganglia, sorry, thalamus, brain stem, either midbrain, pons और medulla, इनमें से कहीं हो सकता है. तो नाउ आई नो कि ओके इसमें मुझे लोकलाइज करना है कहाँ हो सकता है. दैट इज व्हाट आई डू नाउ आई एम डूइंग इज टू लुक फॉर द anatomy of this stroke. Once I've localized कि हाँ ये यहाँ हो सकता है, I should know what is the blood supply of that area. So if I know what is the blood supply of the area, I know which vessel is involved, and that is very important. क्यों? क्योंकि पहली चीज you can do a thrombolysis, that will be easy. Thrombolysis के अलावा there are endovascular procedures where you can go inside the vessel, identify that vessel, whatever is the vessel, you can remove the thrombus or the embolus. To do that you cannot कि ना बॉडी किसी वेसल में चला जाओ, ऐसा नहीं कर सकते आप. You need to be very specific कि कौन सी वेसल का इन्वॉल्वमेंट हुआ है. That will be based on history, and then you have obviously CT angiogram to identify which vessel is occluded. But your history or your clinical examination will help you a lot to identify which part is involved. So सबसे पहले we should know which part of the brain is supplied by what. So when we talk about the medial aspect, remember there are only three arteries which are important for us to know, which are supplying the brain. ACA, anterior cerebral artery, MCA, middle cerebral artery, sorry, the PCA, or the posterior cerebral artery. These three arteries will supply the entire brain. Now, see how they supply the brain. First, we're talking about the medial surface. Only a small part of it, only this small part of it is supplied by the ACA. The rest of the medial surface is supplied by this entire part. Sorry, this small part is supplied by the MCA. On the medial side, this entire half is supplied by the anterior cerebral artery, and the rest will be supplied by the posterior cerebral artery. This is the medial surface being supplied. Now we talk about the superior lateral surface. A small part will be supplied by the anterior cerebral artery. The predominant part will be supplied by the middle cerebral artery, and small part will be supplied by the posterior cerebral artery. So this is the supply on the superior lateral surface. Exam में, if you can be very creative, you can draw color diagrams. This is the maximum I can draw. So this is the possibility. Again, predominantly it will be supplied by the posterior cerebral artery. Some part will be supplied by the middle cerebral artery and the anterior cerebral artery. So this is what you need to first remember, which part is supplied by what. Okay. After this, I'll give you the trick. So this is important because exam में draw करना पड़ता है diagram और सबसे ज़्यादा important नहीं. I'll give you a table in which, depending upon the clinical feature, you'll know which vessel is involved. That will help you a lot. But remember, first ये तीन surfaces of the brain is a very important diagram. If you're writing an exam writing in the exam an answer about stroke and you've not made these three diagrams, the examiner cannot give you marks. Cannot give you full marks definitely for the answer because he wants to see these diagrams. So these are the various blood supply of the surfaces of brain. And we talk about in general the blood supply of the brain. So now how does that happen? Remember, blood supply of the brain is by two systems. One is called the carotid artery. The other is called the vertebrobasilar artery. Vertebrobasilar artery. Now remember, the carotid artery is present here in the carotid triangle. It is divided into two parts. One is the internal carotid artery and the external carotid artery. So we are dealing with the internal carotid artery. Sorry. The internal carotid artery will directly give a branch which is called the anterior cerebral artery. Well, so each side ACA will give a branch which is called the anterior cerebral artery. Renal carotid will also give a branch which is called the middle cerebral artery. The carotid, middle cerebral artery. So this is the anterior cerebral artery, ACA, the anterior cerebral artery, the middle cerebral artery. These are direct branches from the internal carotid, ICA. Now what happens? We have a vertebrobasilar system. Now in the vertebrobasilar system, what will happen? See, there are two vertebral arteries which will enter via the sixth, by the foramen process of the, so via the foramina in the transverse process of six cervical vertebrae. So they will enter from this. These vertebral arteries on from both the sides will join to form the basilar artery. It's called the basilar artery because it sits in the base of the brain. It sits over the brain stem, or the basilar artery. Now it will give numerous branches. Like यहाँ पे एक आएगी आपके पास में anterior spinal artery, not very important अभी के लिए. Then you'll have something called as the posterior inferior cerebellar artery. You'll have the superior inferior cerebellar artery. You'll have the pontine branches, not very important abhi ke liye. Most important, it terminates by giving the posterior cerebral artery, what's called the PCA. So somebody asks you what is the blood supply of the brain, you say the blood supply of the brain is by the carotid system and the vertebrobasilar system. The carotid system or the internal carotid gives two branches in the brain. One is called the anterior cerebral artery and the middle cerebral artery. The anterior cerebral artery and the middle cerebral artery from the internal carotid artery. The vertebral artery enters into by the foramen in the transverse process of six cervical vertebrae. It will enter and ascend and join to form the two vertebral artery will join to form the basilar artery. This basilar artery will terminate by branching into the posterior cerebral artery. This is the basic. इसके ऊपर हम थोड़ा सा और ऐड करेंगे, थोड़ा कॉम्प्लिकेट करेंगे इसको. So what happens कि ACA को कम्युनिकेट करते हैं एक आर्टरी, उसको हम बोलते हैं एंटीरियर कम्युनिकेटिंग आर्टरी, कम्युनिकेटिंग सेरेब्रल आर्टरी, कम्युनिकेटिंग आर्टरी. इसी तरह पोस्टीरियर को भी कम्युनिकेट करता है, तो वी से इट इज अ पोस्टीरियर कम्युनिकेटिंग आर्टरी. Not of very much importance, पर अगर आप याद रखते हैं वेरी गुड. There's something called as anterior communicating artery and posterior communicating artery. ठीक है, इस जाने जरूरत नहीं है डिटेल में. So ठीक, this is what you should know about the vascular system of the heart or the blood supply of the heart. The two artery system which are there, which are involved, and then the vertebrobasilar artery which is involved. Okay, please now make a note of the branches which are talking about. सबसे पहले they have given a one common branch which is one unpaired branch is given. It is called the anterior spinal artery. Remember, it is an unpaired artery. This artery will supply the entire anterior surface of the spinal cord. What happens कि दो वर्टिब्रल आर्टरी से मिलकर बनेगा एक हमारा एंटीरियर स्पाइनल आर्टरी जो नीचे जा रहा है और एक बेसिलर आर्टरी जो ऊपर जा रहा है. ये जो एंटीरियर स्पाइनल आर्टरी है it will continue throughout the entire vertebral column and it will supply the entire anterior spinal tract, the anterior part of the spinal cord. So this will continue. So this is the unpaired anterior spinal artery which is there. Apart from it, what else it will supply? So it will give, so it will first give cerebellar branches. So it will give superior, inferior cerebellar artery. Then it will give posterior, inferior cerebellar artery. It will give you superior, inferior, and then it will give you superior cerebellar artery. तीन cerebellar arteries है, supplying the cerebellum. Anterior inferior cerebellar artery, posterior inferior cerebellar artery, and superior cerebellar artery. So these are the three branches that it will give for a cerebellum. Apart from that, it will give pontine branches to supply the pons, and then it will terminate by giving a PCA, or the posterior communicating posterior cerebral artery, joined together by the posterior communicating artery. Some authors like to mention this कि जब communication हो गया, जो communication से पहले हो उसे वन बोलते हैं. So this becomes A1, anterior cerebral artery का part 1. This becomes A2. If you want to remember, you can remember this. If you don't want to remember, nothing of much importance. ऐसे communication हो गया. Communication से पहले जो artery का part है, that is called P1. Communication के बाद जो part है, that is called P2. This is P1. This is P2. This is A1. This is A2. Some authors like to mention this. Again, it is not of very much importance clinically, but then anatomically, it is so far so named. Any doubt so far? So you can keep your doubts posted in. If there are no doubts, we'll continue forward. And now we'll make one table, which is very, 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 very important. This is how you will localize stroke in your patients. Very important table. We'll talk about the vessel. We'll talk about the vessel that is involved and what is the clinical feature. Now, what happens if the anterior cerebral artery is involved? Now, we know that the anterior cerebral artery will predominantly affect the middle part of the medial surface of the cerebral hemisphere and less part of the lateral hemisphere. So, from the knowledge of neuroanatomy, we also know that the medial part which is there, that has got more of a lower limb supply. Okay. So that is how the homunculus or the motor homunculus is designed. How is it designed? We'll start from here. So first you have the lower limb, then you go laterally, you'll have the upper limb. Once you after that upper limb, you'll have the hand, which has got a very large portion. Then you have the tongue. Then you have the face and then the tongue. So this is how you have the distribution over the motor homunculus. So remember, if there is weakness more in the lower limb than in the upper limb, you know that the cerebral cortex is involved. First things first, and second, since there is more weakness in the lower limb, that means the anterior cerebral artery must have been involved. So remember, if the ACA is involved, there will be weakness in legs will be more than arms. अब इसका मतलब क्या है? इसका मतलब ये है कि अपने पेशेंट से पूछा जब स्ट्रोक हुआ था तो क्या कमजोरी आई थी. तो पेशेंट सेज कि हाथ में कमजोरी आई थी और पैर में कमजोरी आई थी. नाउ यू आस्क द पेशेंट कि आप की कमजोरी कितनी थी. तो हिल से कि हाथ में थोड़ा हिला पा रहा था लेकिन पैर तो बिल्कुल भी नहीं हिला पा रहा था. मैं अपने आप खड़ा ही नहीं हो सकता था. दैट मीन्स देयर इज बोथ प्रॉक्सिमल एज वेल एज डिस्टल वीकनेस एंड देयर इज कंप्लीट वीकनेस. तो पावर लोअर लिम्ब की जीरो, अपर लिम्ब में देयर वाज स्टिल सम पावर. दैट मीन्स दिस इज वेयर जब वीकनेस दोनों लिम्स में डिफरेंट होती है, we use a term called as differential weakness or differential hemiplegia. So there are two terms that you should know. One is called as differential hemiplegia. The other called as differential weakness. Now what happens in differential weakness is कि upper limb and lower limb में the weakness is not the same. That means कि जो power है वो दोनों में different होंगे. In dense hemiplegia, both in the upper limb as well as the lower limb, the power will remain the same. So this is called differential weakness. differential weakness or differential hemiplegia. डिफरेंशियल मतलब डिफरेंट है वीकनेस, तो लेग्स में ज्यादा है और आर्म्स में कम है, दैट इज डिफरेंट. नाउ वी गो टू एमसीएल, middle cerebral artery. The middle cerebral artery is a very tricky artery. We'll first look at the anatomy of the middle cerebral artery. See, after the middle cerebral artery originates from the internal carotid artery, first there will be a stem of the, there is a stem which is there. This is called the stem of the middle cerebral artery. The first part which is there is called the stem of the middle cerebral artery. After this, the middle cerebral artery divides into two parts called the M1 division, continues for some time and then divides into M2. So this will become the M1 division. This becomes the M2 division. Now we have two parts, something called the M1 division, something called the M2 division. The M2 division will then divide into two parts and supply the brain. So M2 has got two parts, a superior division and an inferior division. Very important, very critical to understand. This is what we're talking about, the middle cerebral artery. The middle cerebral artery, after its origin from the internal carotid, will be first a stem is formed. The stem then divides into two, the M1 and M2. M2 divides into two, superior and inferior. Further complicating it, the stem will give some branches, very thin branches, which are called the lenticostriate branches. Very, very important when you talk about something called as brainstem, something called as lacunar strokes. अभी के लिए lenticulo lenticulostriate branches. These are the, sorry. These are the so what we're talking about is the anatomy of the middle cerebral artery. The middle cerebral artery starts from this starts the stem, divides into M1 and M2. M2 divides into superior division and inferior division, and it gives some branches called the striate branches. Okay, so what will happen? So if the stem is involved, that means the stroke is localized to internal capsule. Stroke is localized to internal capsule. The internal capsule, that is subcortical white matter. So now what happens? If the stroke is localized to the internal capsule, there will be dense hemiplegia. And we all know that in case of dense hemiplegia, there will be equal. So weakness in arm is equal to weakness in legs, both by history and examination. If you examine the patient and you find that the power is both, both the both upper right upper limb, left upper limb and the left lower limb, the power is 2/5. Now you know that since the power is equal in both sides, since the power is equal in both the limbs, that means the weakness is also equal in both the limbs. And since the weakness is also equal in both the limbs, then that has to be localized into the internal capsule. So that means if the weakness is equal, that means it localizes to the internal capsule, and you know that the stem of the MCA is involved. Okay. Now M1 is a very silent one in which the internal capsule is paired. So in case if the M1 is involved, there will be no or they will be very unlikely to have a massive stroke. So weakness may also not be present. That could be the presenting feature. Now in M2 you can have somewhere there is involvement of the superior division or the inferior division. Here what will happen? Since the internal capsule is paired, so there is no involvement of the internal capsule. However, motor symptoms will also be minimal. Motor symptoms will also be minimal. So what happens? M1 is not of very much importance clinically. What is more important is to identify whether the stem is involved and whether the superior division or the inferior division is involved. Now, in the superior division and inferior division, remember, when you talk about weakness, in terms of weakness, when the superior division is involved, the weakness will be more in the arm than in the leg, and that has to be because since this artery has once it has from here it has crossed the brain matter, it has come out on it. Now this is on the lateral surface of the brain. The superior artery will go and supply the superior part of the lateral surface of brain. अगर ये सुपीरियर पार्ट ऑफ द लैमेलर सर्फेस ऑफ ब्रेन सप्लाई कर रहा है, तो इट इज सप्लाइंग दैट एरिया ऑफ द मोटर कॉर्टेक्स व्हिच इज सप्लाइंग द आर्म्स. देयर विल बी मोर वीकनेस इन द आर्म्स than in the legs. पहली बार. And inferiorly we don't have any motor cortex. Therefore, inferiorly there will be no weakness. There is no weakness inferiorly. First thing, more important and very distinguishable feature is that we know that we have something, we have two speech areas. One is called the Broca's motor area, that is called the Wernicke's sensory area. Now what happens? If the superior division is involved, मोटर जाएगा ना, तो मोटर मतलब ब्रोकाज मोटर जाएगा. देयर बी ब्रोकाज एफेजिया सुपीरियर में, विल ब्रोकाज एफेजिया. And if the inferior division is gone, so the Wernicke will go, will be Wernicke's aphasia. Wernicke's aphasia. Okay, we'll take it again slowly and we'll try to understand each and everything so far. Remember, if the ACA is involved, the anterior cerebral artery is involved, it predominantly supplies the medial surface of the brain. That means it predominantly supplies the legs. So if the ACA is gone, there will be weakness more in the legs than in the arms. So if you know that the patient has got more weakness in the legs than in the arms, then therefore the ACA must have gone. Now we come to MCA. MCA has got various parts. If the stem is involved, that means the internal capsule is gone. If the internal capsule is gone, we know that there will be dense hemiplegia. That means arms is equal to legs. So if the weakness in both the arms and legs are equal, then we know that the localization of this stroke is in the stem of the MCA. If the M1 is involved, there will be minimal motor symptoms and the internal capsule is also spared. So predominantly the patient may not have any symptom as well. That is how silent M1 can be. So it is not very clinically important for us. Next one we need to identify is M2. M2 can have two parts, either a superior division or an inferior division. Superior division will go and supply the superior part of the lateral surface of brain. On the superior part of the lateral surface of brain is the predominant supply of the arms. So if the weakness is more in the arm or the legs than the legs, that is localized to the superior division of the M2. Or if there is a Broca's aphasia which is present. And if there is no weakness, but only and only there is Wernicke's aphasia that is present because of the sensory part which is there, then it is because of the inferior division. The third vessel which is there, blood vessel which is there, is the posterior cerebral artery. Now remember, first of all, this is not UG level because posterior cerebral artery leads to formation of something called as brainstem syndromes, which are beyond our capability to understand them as of now. So that is not UG level expected. If you can remember them, very good. There are few named syndromes, a lot of named syndromes. If you open Balloon, I think maybe there are 15 to 20 named syndromes. Wallenberg syndrome, Claude syndrome, Perinaud syndrome. There are a lot of named syndromes. No need to go into complexities of these. Just remember that if the PC is involved, there will be posterior circulation stroke that will involve the brain stem. In the brain stem, there will be named syndromes, like for example, lateral medullary syndrome, in which there is only sensory involvement. Just remember this. There's something called as lateral medullary syndrome, in which there will be only sensory involvement and no weakness, first of all. If the PC is involved, if the PCA is involved, there will be involvement of the branches of the PCA or before PCA. Like for example, cerebellum may be involved, cerebellar strokes or something. There may be the pons may be involved, so there will be brainstem stroke. Now there is one characteristic feature about brainstem stroke जो समझना बहुत जरूरी है. I'll rub this, and that will be the last part of our discussion today. Something called as what is the difference between brainstem syndrome, brainstem stroke. So what happens कि अगर ब्रेन स्टेम का कोई पार्ट इन्वॉल्व है, फॉर एग्जाम्पल कि पॉन्स चला जाए, मिड ब्रेन चला जाए, मेडुला चला जाए, कोई भी जाए इनमें से, तो देयर इज एंटिटी कॉल्ड एज क्रॉस्ड हेमिप्लेजिया, which is very disturbing. I'll tell you why. Something called as crossed hemiplegia. समझना धीरे धीरे. Now see, this is the cerebral cortex. Giant cell pyramidal cells. यहाँ से ये निकले, they will decussate and go in the brain stem. ठीक है. यहाँ हम बात कर लेते हैं किसी ब्रेन स्टेम की. So for example, I'm taking mid brain. So mid brain में I have this beautiful nucleus which is sitting here, third cranial nucleus. So what happens? कि एक ब्लड वेसल होगा जो सप्लाई कर रहा होगा मिड ब्रेन को, हम मान लेते हैं कि ये जो ब्लड वेसल है सप्लाई कर रहा है मिड ब्रेन को। ठीक है, जब ये मिड ब्रेन को सप्लाई कर रहा है और इसमें स्ट्रोक हो गया, नाउ रिमेंबर इसमें स्ट्रोक हो चुका है ब्रेन, इस वेसल में स्ट्रोक हो गया, दिस वेसल इज ऑक्लूडेड पूरी की पूरी। इसकी वजह से दो चीजें खराब हो जाएंगी। क्या? ये कॉर्टिकोस्पाइनल ट्रैक्ट गया और ये थर्ड क्रीनियल नर्व गया, ये दो चीजें चली गई ना। अगर ये फाइबर यहाँ यहाँ कट गए हैं, ये क्रॉस ओवर करने वाले थे। अभी हम मान लेते हैं ये पेशेंट का राइट साइड है और ये पेशेंट का लेफ्ट साइड है। दैट मीन्स दिस पेशेंट विल हैव हेमीप्लीजिया ऑन द राइट साइड, क्योंकि सॉरी दिस इज सप्लाई द लेफ्ट साइड ऑफ द बॉडी, दिस इज बीइंग कट, तो लेफ्ट साइड ऑफ द बॉडी को सप्लाई नहीं कर पाएंगे। दिस पेशेंट विल हैव लेफ्ट साइडेड हेमीप्लीजिया, हेमीप्लीजिया कोई प्रॉब्लम नहीं है, समझ आता है कि हाँ ठीक है ऑपोजिट साइड में से जाती है। तो अगर लेफ्ट साइड ऑफ द बॉडी गई हुई है तो राइट साइड कॉर्टेक्स में लीजन होगा, स्ट्रोक। और अगर उसका ऑपोजिट गया है तो हाँ कोई प्रॉब्लम नहीं है यहाँ पे। ठीक, नाउ दिस ग्रीन लंप इज इन्वॉल्व एट द लेवल ऑफ द न्यूक्लियस इज जस्ट लाइक एंटीरियर हॉर्न सेल। तो जैसे हम बात करते हैं, जब हम बात करते हैं नर्व्स की, हमने बोला कि पेरिफेरल नर्व्स कहाँ से शुरू होते हैं, एंटीरियर हॉर्न सेल से। एंटीरियर हॉर्न सेल और उसके नीचे जितना भी सब कुछ है एलिमेंट। तो ऐसे ही क्रेनियल नर्व का जो न्यूक्लियस है वो और उसके नीचे जितनी भी नर्व है वो एलिमेंट है। तो विल बी element type of third, sorry, right third cranial nerve palsy, cranial nerve palsy, so we know that there will be some kind of a squint, but then now remember this is called crossed hemiplegia. Crossed का मतलब क्या है कि जो कॉर्टिकोस्पाइनल ट्रैक्ट है वो तो ऑपोजिट साइड का इन्वॉल्व है, लेकिन जो ब्रेन स्टेम का न्यूक्लिया है वो सेम साइड का इन्वॉल्व होता है, इसीलिए बोलते हैं उसको क्रॉस्ड। क्रॉस मतलब कि कहीं तो राइट साइड ऑफ द बॉडी इन्वॉल्व कर रहा है और कहीं तो लेफ्ट साइड ऑफ द बॉडी इन्वॉल्व कर रहा है। दिस इज कॉल्ड क्रॉस हेमिप्लीजिया। सो whenever this kind of presentation will occur, crossed hemiplegia with cranial nerve involvement of the opposite side, या फिर cranial nerve nuclei of the same side, then this is then that means the stroke is localized to brainstem। क्योंकि ये सिर्फ ब्रेनस्टेम में पॉसिबल है। क्यों? अब देखिए, क्योंकि इसके ऊपर अगर हम बात करते हैं तो ऊपर हमेशा क्रॉस ओवर होता है, मतलब कॉन्ट्रालैटरल सप्लाई होता है। तो अगर इसके ऊपर स्ट्रोक होता तो लेफ्ट साइड का क्रेनियल नर्व जाता, और लेफ्ट साइड का ही, क्योंकि ये तो अबव द न्यूक्लियस हो गया तो ये ह्यूमन टाइप ऑफ लीजन होता और वो भी ऑपोजिट साइड का लीजन होता। तो इसके अगर ऊपर होता तो लेफ्ट साइड ऑफ द बॉडी जाती और उसके साथ में लेफ्ट साइड ऑफ द क्रेनियल नर्व भी जाता। तो अगर सेम साइड का क्रेनियल नर्व जाए और सेम साइड का सेम साइड का क्रेनियल नर्व भी जाए और सेम साइड की वीकनेस भी है बॉडी में, देन दैट मीन्स इट इज नॉट इन द ब्रेन स्टेम। और अगर सेम साइड का आपका क्रेनियल सेम साइड का जा रहा है, सेम साइड की बॉडी में वीकनेस है, लेकिन जो क्रेनियल नर्व इन्वॉल्वमेंट है वो एलिमेंट टाइप है और ऑपोजिट साइड में, then that in that case it will be localized to the brainstem, and this phenomenon is called crossed hemiplegia. Any doubt so far? Anything that you want me to repeat? Aram se take your time, we'll have 5 more minutes. We talked about the exact features that we have to look for. So if the weakness is more in the arms than in the legs, then you know this will be in the superior division of M2. If it is more in the legs, less in the arms, you know this is localized to the anterior cerebral artery. If there is Wernicke's aphasia, you know this is inferior division of M2. If it is Broca's aphasia, this is again localized to the M1 division of the superior division of M2. If the brain stem is involved, if the posterior cerebral artery is involved, it will lead to posterior circulation stroke. It will lead to brain. Okay, I'll repeat. Cross hemiplegia. See, I'll give you an example. So for example, if there is a stroke on the right brain stem पे मेरा stroke हुआ है, अगर मेरा स्ट्रोक राइट ब्रेन स्टेम पे हुआ है तो मेरे फाइबर्स तो नीचे क्रॉस करेंगे। तो अगर राइट साइड में स्ट्रोक है तो मेरे लेफ्ट साइड की बॉडी का वीकनेस आएगा। क्योंकि मैं अपने हैंड्स मूव नहीं कर सकता, अपने लोअर लिम्ब मूव नहीं कर सकता, क्योंकि जो कॉर्टिकल स्पाइनल ट्रैक्ट है वो नीचे जाकर क्रॉस होंगे। जो मैंने जो फाइबर्स को अभी प्रॉब्लम हुई है वो फाइबर्स ऑपोजिट साइड के, ठीक है। तो अभी के लिए अगर राइट साइड में ब्रेन स्टेम इन्वॉल्वमेंट हुआ है, तो जो स्ट्रोक होगा या फिर जो वीकनेस होगी राइट आर्म और राइट लोअर लिम्ब में, दैट विल बी ऑन द ऑपोजिट साइड। तो हमने बोला कि ठीक है लेफ्ट साइड में हो गया। तो क्रेनियल नर्व न्यूक्लियस गया है, वो जाएगा सेम साइड का, ऑब्वियसली बात है। वही चीज मैंने बताई है, जो क्रेनियल नर्व न्यूक्लियस गया है वो गया सेम साइड का। एक बार अगर क्रेनियल नर्व सेम साइड का जाएगा, तो ये तो आपका राइट साइड है ना, तो पेशेंट की जो राइट आई को जो सप्लाई कर रहा है आपका राइट क्रेनियल नर्व, यानी कि राइट थर्ड नर्व, राइट ऑक्यूलोमोटर नर्व, दैट विल बी इन्वॉल्व। तो अभी पेशेंट को वीकनेस पूरी बॉडी में लेफ्ट साइड में है, और आई में वीकनेस राइट साइड पे, राइट आई इज अफेक्टेड। तो ये देख लो आपकी एक क्रॉसिंग हो चुकी है। क्रॉसिंग का मतलब ये है कि ऑपोजिट चल रहा है, आधी बॉडी अलग चल रही है, यहाँ वीकनेस अलग चल रही है, और यहाँ पे आई में एक अलग वीकनेस हो रही है। दिस इज कॉल्ड क्रॉसिंग, दिस इज कॉल्ड क्रॉस हेमिप्लीजिया। ये सिर्फ और सिर्फ ब्रेन स्टेम में पॉसिबल है। क्यों? क्योंकि आपने बोला कि इसके ऊपर जो फाइबर्स होते हैं वो क्रॉस ओवर करते हैं, जो क्रेनियल नर्व को सप्लाई करते हैं वो भी। इसका मतलब कि इसके ऊपर अगर कहीं भी स्ट्रोक अगर हो, फॉर एग्जाम्पल अगर यहाँ स्ट्रोक होता, तो इसका मतलब है कि चलो ठीक है ये वाला कॉर्टिकल स्पाइनल ट्रैक्ट चला गया, नीचे क्रॉस होने वाला था ये, तो इसका मतलब ऑपोजिट साइड में वीकनेस आ गई। तो अगर राइट साइड इन्वॉल्व था, तो लेफ्ट साइड ऑफ द बॉडी में वीकनेस आएगी। तो लेफ्ट साइडेड वीकनेस है बॉडी में। अभी जो क्रेनियल नर्व है, ये जो फाइबर है लेफ्ट साइड को क्रेनियल नर्व सप्लाई करने वाला था, तो लेफ्ट आई में प्रॉब्लम आएगी। तो अगर प्रॉब्लम लेफ्ट आई में है और लेफ्ट साइड ऑफ द बॉडी में, तो ये सेम साइड ऑफ द बॉडी हो गया। दिस इज अनक्रॉस्ड हेमिप्लीजिया, इसमें कोई क्रॉसिंग थोड़ी ना हुई है, दोनों लेफ्ट ही है। लेकिन अगर ऐसा हो कि वीकनेस जो है वो राइट साइड, वो लेफ्ट साइड ऑफ द बॉडी में है, लेकिन तो क्रेनियल नर्व सप्लाई कर रही है, जैसे फॉर एग्जांपल थर्ड क्रेनियल नर्व ऑक्यूलोमोटर, वो राइट आई को सप्लाई कर रही है, तो वो राइट थर्ड अगर ऑक्यूलोमोटर नर्व इन्वॉल्व हुई है, इसका मतलब क्रेनियल नर्व ऑपोजिट साइड की इन्वॉल्व होती है, वीकनेस बॉडी में उल्टा साइड आ रहा है। दिस इज कॉल्ड क्रॉस हेमिप्लीजिया। आकाश समझ में आया क्या? दोबारा रिपीट करना है। राइट राइट, दैट इज एब्सोल्युटली करेक्ट। ओके, कोई और डाउट? हम कुछ भी रिपीट कर सकते हैं, ऐसा कुछ नहीं है। पूरी क्लास में अभी तक कुछ भी समझ में नहीं आया तो हम वो रिपीट करते हैं एक बार फिर से, तो कोई दिक्कत नहीं। एक बार गो थ्रू कर लीजिए, एक बार सुपरफिशियल रीड कर लीजिए, कुछ भी जो समझ में नहीं आया। दिस इज व्हाट इज इंपॉर्टेंट। क्लिनिक्स में आपको जाके बस इतना ही सीखना है कि आपको साइंस एलिसिट करने हैं और आपको आइडेंटिफाई करना है कि ये कहाँ पे लीजन हो सकता है पॉसिबल, कौन सी ब्लड वेसल इन्वॉल्व होती है। अगर आपने इतना बता दिया तो फिर मोर देन 75% आपकी आपने काम कर दिया है। उसके बाद मैनेजमेंट है, थ्योरी है, वो हम बढ़ा देंगे, उसको कोई दिक्कत नहीं है। कोई भी डाउट है अपना टाइप कर सकते हैं। मैं मेरी तरफ से एडवाइस यही है कि आप एक बार जाएं, अर्चित बलूर खोलें, और एक बार अच्छे से अर्चित बलूर से आप रीड कर लें। डिस्कशन ऑन स्ट्रोक जो उन्होंने दिया है, बहुत ही अच्छा डिस्कशन ऑन स्ट्रोक दिया है, वो एक बार रीड कर लें। अपने नोट अच्छे से रीड कर लें। जो भी बुक आप फॉलो करते हैं, वो कोई भी बुक आप फॉलो करते हैं वो बुक रीड कर सकते हैं। तो अभी तक आपकी सिर्फ और सिर्फ इन्वेस्टिगेशन और मैनेजमेंट बचा है स्ट्रोक का, वो बहुत आसान है, उसमें मुश्किल नहीं है, वो हम बात कर लेंगे उसकी। जो अभी नई गाइडलाइन चाहिए उसके हिसाब से बात कर लेंगे। बट क्लिनिकल कोरिलेशन ऑफ स्ट्रोक बहुत इंपॉर्टेंट है। उसमें आपको थ्योरी के लिए आपको पता होना चाहिए व्हाट आर द कॉजेज ऑफ स्ट्रोक जो आपको वाइवा जा सकते हैं, व्हाट आर द कॉजेज ऑफ स्ट्रोक इन यंग, उसकी हमने बात कर ली है। हाउ विल यू असेस द रिस्क इन अ पेशेंट विद स्ट्रोक, और उसके बाद अभी हमने बात कर लिया कि हाउ विल यू लोकलाइज स्ट्रोक, व्हाट इज द पैथोएनाटमी एंड पैथोफिजियोलॉजी। पैथोफिजियोलॉजी इसलिए इंपॉर्टेंट है क्योंकि तभी आप अंडरस्टैंड कर पाएंगे आपके पेशेंट को क्या हो रहा है, आपको कैसे मैनेज करना है उस पेशेंट को। पैथोएनाटमी इज वेरी इंपॉर्टेंट। ओके, ठीक, बराबर। वेरी 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 गुड क्वेश्चन, ब्रोकासोफेजियन वर्निकेफेजिया। ओके, दिस इज अ क्वेश्चन ऑफ क्लिनिक्स, और मैं इसको अभी डिस्कस कर लेता हूँ। ओके, so from my side the class is over. Aphasia is a very very good question which is being very very rightly asked. जिनको सुनना है वो सुन सकते हैं, जिनको लगता है कि थोड़ा कंफ्यूजिंग हो जाएगा क्लिनिक में सुनना है वो क्लिनिक में भी सुन सकते हैं। ठीक है, ओके, विल टॉक अबाउट अफेजिया। दिस इज अ वेरी इंपॉर्टेंट क्वेश्चन, दिस इज अ वेरी क्लिनिकल क्वेश्चन। दिस इज नॉट रिलेटेड, अभी हम लोग ज्यादा डिस्कस नहीं करेंगे इसको इन रिस्पेक्ट टू स्ट्रोक। सॉरी। ओके, प्लीज टेक अ फ्रेश शीट ऑफ पेपर एंड राइट अफेजिया as a heading. This is a special class in itself, and this is a tricky topic, और बहुत ही खूबसूरत टॉपिक भी है. We'll talk about this as well. This अभी do not mix this with stroke बस. We'll talk about aphasia. Okay. सबसे पहली चीज जो होती है something called as dysarthria. Can anyone of you tell me what is the difference between dysarthria and aphasia? Let people type. Okay, very good. Dysarthria is problem in articulation. Okay. Aphasia is a disorder of language. अब इसका मतलब समझते हैं होता क्या है पहले तो. Again, it is very very beautifully written in Arshid Balur. आप पढ़ सकते हैं वहां से. तो this is language का problem. This is speech का problem. Okay. We'll start with language and speech first. Okay. So whenever you do a neurological examination, you look for higher mental function and then you come to language and speech. First thing that you should know what is speech and what is language. Speech means to produce sounds. जैसे कि animal भी करते हैं. Coo, ka, bow. So anybody that produces a sound or any organism that produces a sound is speech. Language means adding sense to that speech. For example, मेरा नाम इजाज है. So when I speak this something, a sense is made out of it. So now this is what is called language. So now what happens? जैसे speech जो है, तो स्पीच एनिमल्स में भी प्रेजेंट होता है. जिसे हम बोलते हैं कि स्पीच इज अ लोअर क्रेनियल फंक्शन और इट इज अ ब्रेन स्टेम फंक्शन. क्यों? क्योंकि साउंड को प्रोड्यूस करनी है, उसके लिए 9th 10th और 11th क्रेनियल लोब चाहिए और 12th क्रेनियल लोब. 9th 10th 11th 12th से आप कोई भी साउंड प्रोड्यूस कर सकते हैं. वट एवर साउंड दैट यू वांट टू प्रोड्यूस फ्रॉम द लैरिंग्स. और लैरिंग्स को जो नर्व सप्लाई है और लैरिंग्स और टंग है जो आपको हेल्प कर रहे हैं साउंड प्रोड्यूस करने में. एंड दैट इज द नर्व सप्लाईज 9 10 11 12. तो ये जो आपके पास 9 10 11 12 है, ये आपको साउंड प्रोड्यूस करने में हेल्प कर रहे हैं. अगर इनमें कोई प्रॉब्लम होगी तो उसकी वजह से आपका आर्टिकुलेशन प्रॉब्लम होगा, यानी स्पीच का प्रॉब्लम होगा. दिस इज कॉल्ड डिसआर्थरिया. लेकिन अगर आपका हायर क्रेनियल फंक्शन, फॉर एग्जांपल कॉर्टेक्स में कोई प्रॉब्लम है, तो जो कॉर्टेक्स में प्रॉब्लम होती है उसकी वजह से प्रोग्रेस में जो होगा दैट इज कॉल्ड एज लैंग्वेज डिसऑर्डर और अफेजिया. जैसे 9 10 11 12 में कोई प्रॉब्लम हो सकती है, वैसे ही कॉर्टेक्स में क्या प्रॉब्लम हो सकती है. तो कॉर्टेक्स में 3 सेंटर्स है जिनमें मेन प्रॉब्लम हो सकती है. वर्निकिस, ब्रोकास और आर्कुएट फैसिकुलस. दैट इज अफेजिया. अभी हम बात करेंगे अफेजिया की अच्छे से डिटेल में. डिसआर्थरिया के बहुत सारे टाइप्स होते हैं जो मैं नहीं बताऊंगा आपको, आप पढ़ सकते हैं किताब से. अभी मैं आपको बताता हूँ कि हाउ टू डिफरेंशिएट बिटवीन डिसआर्थरिया एंड अफेजिया. You ask the patient to say some words. Like for example, जो as per convention हम यूज करते हैं, हम बोलते हैं पेशेंट को बोलने के लिए बोलो पटाका और बार बार बोलना है पटाका. The use of पटाका is क्योंकि उसमें क्या होता है, सॉरी, तो पटाखा है उसमें क्या होता है इसमें कि the word per will come from the lips, which is called lingual. The word ter comes from the tongue. Sorry. The word per comes from the lips, which is called labial. The word ter comes from the tongue, which is called the lingual. And the word kh comes from the throat, that is called the gutturals. So guttural, lingual, labial. Per, ta, ka. That is how. We ask the patient to say this word continuously. तो क्या होता है जब वो बार बार बोलते हैं उसको, तो if there is a problem of the cranial nerves, he will have some problem in saying a specific word. Like per taka में he'll have problem in saying t. He will have some problem in saying kh. जैसे पटक पटक पटक. That is how there will be a problem in the articulation. The next word that you'll ask the patient to say is Rashtrapati Amritsar gaye. That is the complete sentence that you need to ask him to say. So he will have a particular, if there is a problem in saying only a particular word, say amrit, rit, rit. So if he has a problem in saying a particular word, then that is a problem of speech. But if he cannot say the entire sentence, or if there is a problem कि जिसमें he is not able to say, if he has a problem in articulating each and every word, then most likely the problem is not in the speech, but is in the language. So you have to always rule rule out whether you're dealing with dysarthria or you're dealing with aphasia. Now, when we talk about aphasia, what happens in the brain? You have got something called as the what do you have? You have here the Broca's motor area. Here you have somewhere you have the Wernicke's sensory area, and something that connects these two is called the arcuate fibers, also called the arcuate fasciculus. This is the anatomy that you need to know. Now, aphasia can be of 7 types. जाने की जरूरत नहीं है, 3 टाइप काफी है. It can actually be of 10 types, but ठीक है, 3 टाइप्स बहुत इंपॉर्टेंट है जो काफी है, वो हम बात करेंगे. Now what happens? ब्रोकास का एरिया मोटर एरिया है. तो मोटर एरिया जो होता है दैट विल हेल्प यू इन आर्टिकुलेशन. तो फॉर एग्जांपल क्या होता है आर्टिकुलेशन, अभी हम जब भी हम लैंग्वेज की हम बात करते हैं तो लैंग्वेज में हम पहले 3 चीज चेक करते हैं: कॉम्प्रिहेंशन, रेपिटेशन एंड फ्लुएंसी. इसका मतलब क्या है? तो कॉम्प्रिहेंशन का मतलब है वट एवर आई आस्क द पेशेंट इज एबल टू अंडरस्टैंड इट. फॉर एग्जाम्पल, आई टेल माय पेशेंट आपका नाम क्या है, ही सेज मैं जुहू तारा रोड पे रहता हूँ. These are two unrelated things. उसका comprehension intact नहीं है, पहली बात. Second is repetition. You don't ask for repetition, you look for repetition. Whether he is able to repeat words or not. तो जब आपने बोला पेशेंट को बोलने के लिए पटाखा 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 बोलते रहो, whether he is able to repeat it or not. If he is not able to repeat it, then that means repetition is impaired. Third thing is fluency. So is there the problem with fluency is there a problem in continuously speaking words? For example, I can stop multiple times and speak words like मेरा नाम एजाज है. So this is the problem with fluency. If you ask me the question कि आपका नाम क्या है, I'm telling the right answer. लेकिन the problem कहाँ पे है कि मैं अटक अटक के बोल रहा हूँ. That is what is called as fluency. So there is a problem in the fluency. So now what happens? Each of these is controlled by a particular center. तो ब्रोकास मोटर एरिया, मोटर क्या करेगा? कंटिन्यूस कराएगा किसी भी काम को. तो अगर ब्रोकास मोटर एरिया गया है तो इसका काम है फ्लुएंसी. वर्निके सेंसरी एरिया, सेंसरी एरिया अंडरस्टैंडिंग में हेल्प करेगा. दिस इज कॉम्प्रिहेंशन. एंड जो ये फाइबर्स है विच आर कॉल्ड एज आर्कुएट फैसिकुलस, these will help in repetition. Now coming to that question कि ब्रोकास में क्या होगा, वर्निकेस में क्या होगा और आर्कुएट फैसिकुलस में क्या होता है. Now what happens is कि आपके अफेजिया जो है वो बहुत सारे टाइप के हो सकते हैं. हम अभी बात कर रहे हैं इंपॉर्टेंट टाइप्स की. इसमें सबसे पहले मतलब क्या, ब्रोकास अफेजिया, वर्निकेस अफेजिया. तो ब्रोकास अफेजिया में क्या होगा कि जो ब्रोकास एरिया दैट विल बी अफेक्टेड, ये आउट हो जाएगा. ये आउट होते ही फ्लुएंसी चली जाएगी और इसके साथ देखा गया है कि इसके साथ में रेपिटेशन भी चला जाता है. तो व्हाट आर द थिंग्स दैट यू विल लूज अगर हम बात करते हैं तो कॉम्प्रिहेंशन है, रेपिटेशन है और फ्लुएंसी है. तो ब्रोकास अफेजिया में कॉम्प्रिहेंशन इज नॉर्मल, रेपिटेशन इज लॉस्ट, फ्लुएंसी इज लॉस्ट. तो अगर एक पेशेंट आपके पास ब्रोकास अफेजिया का आएगा और आपसे पूछते हैं कि आपका नाम क्या है, तो वो कह रहे हैं कि चांद रात में आता है. दैट मीन्स कि उसका दैट मीन्स उसका कॉम्प्रिहेंशन चला गया है. कॉम्प्रिहेंशन इज लॉस्ट, रेपिटेशन कॉम्प्रिहेंशन इज लॉस्ट, repetition maybe repetition is also lost, but fluency is normal. If this is a scenario, then that patient will be of Wernicke's aphasia. The patient is able to tell you the right thing कि मेरा नाम संजय है, but is able to break it and tell you. That means उसकी fluency चली गई है, उसकी repetition चली गई है, लेकिन comprehension अभी भी intact है. That is Broca's aphasia. The third possibility is कि comprehension भी normal है, fluency भी normal है, लेकिन repetition loss हो गया. जिसको हम बोलते हैं कंडक्शन अफेजिया, इसमें द लीजन विल बी हियर ओनली इन द आर्कुएट फैसिकुलस. So if it is only in the arcuate fasciculus, then repetition will go. This is called conduction aphasia. There is another possibility कि सब कुछ चला जाए. That is called as global aphasia. There are 4 types of aphasia. अभी हम लोग जिनकी बात कर रहे हैं, ब्रोकास, वर्निके, कंडक्शन एंड ग्लोबल aphasia. इसके अलावा there are also aphasia like ट्रांसपार्टिकल, ट्रांसमोटर, जरूरत नहीं, इतना काफी है. Once your patient has got these three things normal, then you ask for naming, reading and writing, और उसके बेसिस पे you label the patient as having alexia, agraphia and anomia. जरूरत नहीं है, अगेन कोई जरूरत नहीं है, इतना काफी है जानना कि आपको तीन इंपॉर्टेंट चीजें होनी चाहिए: कॉम्प्रिहेंशन, रेपिटेशन एंड फ्लुएंसी. डिपेंडिंग अपॉन क्या अफेक्टेड है, उसके बेसिस पे यू विल आइडेंटिफाई व्हाट काइंड ऑफ अफेजिया इट इज. तो आपके दिमाग में ये टेबल बन जानी चाहिए कि हाँ ठीक है, व्हाट आई एम डीलिंग विद. लेकिन सबसे इंपॉर्टेंट चीज इज टू आइडेंटिफाई कि आप डिसआर्थरिया से डील कर रहे हैं या फिर अफेजिया से डील कर रहे हैं. आई होप आई आंसर्ड योर क्वेश्चन. Okay, how is the repetition? Danish, I didn't get the question. Danish, can you please repeat the question for me? How is the repetition lost in this case? Okay, so what happens if I've understood the question right? What happens? It is not just that the Broca's area or Wernicke's area which is there is they're only responsible for fluency. Actually, repetition जो है, it is not a simple game work. क्योंकि उसमें आप you have to understand also, you have to repeat it continuously also, and then you have to sustain that pattern also. So for that, comprehend for repetition, all the three are involved. But predominantly, it is a function of arcuate fasciculus. That is why in Broca's aphasia, repetition is also lost. It is not because the lesion has extended into the arcuate fasciculus, but then there is some repetition, there is some function of the repetition also there in Broca's motor area. Second, if the patient is having difficulty in articulation, he'll have difficulty in repetition also. How? Because he'll take more time to repeat words. So there will be a misjudgment that may happen. So it is not very sacrosanct, lekin हाँ, if he is able to do both the things, like he can fluently tell you whatever you ask him, but when you ask him to repeat specific words and he is not able to repeat those specific words, then that means there is a problem. Then that means repetition is impaired, and that is where localization will occur to the arcuate fasciculus, which is a conduction like this. Hope Danish have answered your question. Okay. Very nice, very good doubts. Any more questions? Okay. So there are no more questions. We'll close the portal now, abs. And if there are any more doubts, you can always leave a text for me or you can call. That is not a problem. Thank you, everyone. Thank you. Thank you, abs. Thank you, Devansh. Thank you, everyone.